Welcome to NCLEX-Map. Today we uncover why patients with atrial fibrillation are placed on Coumadin or other anticoagulants. In atrial fibrillation, the upper chambers of the heart do not contract effectively. Blood pools in the left atrial appendage, forming clots. When these clots travel to the brain, they cause embolic stroke. Anticoagulants reduce this risk by preventing clot formation. Current guidelines from the American Heart Association, the American College of Cardiology, and the European Society of Cardiology recommend anticoagulation when the annual stroke risk is 2% or greater. The risk is estimated using the CHA-2-DS2 VASC score. Most patients beyond minimal risk benefit from oral anticoagulation. Aspirin alone is no longer advised. Direct oral anticoagulants, known as DOACs, are the first choice for most patients without valvular heart disease. These include apixaban, rivaroxaban, dabigatran, and edoxaban. They provide equal or better stroke prevention and lower brain bleed rates compared with warfarin. They also do not require blood level monitoring, making them convenient and safer for many patients. However, patients with mechanical heart valves or severe rheumatic mitral stenosis must use warfarin because direct oral anticoagulants are contraindicated. For those on warfarin, the therapeutic range for the International Normalized Ratio, or INR, is between 2 and 3. For mechanical mitral valves, the target is between 2.5 and 3.5. Bleeding risk does not mean we avoid anticoagulation. The HASBLED tool identifies modifiable risks such as uncontrolled blood pressure, anemia, alcohol use, or interacting drugs. Nurses are key in teaching, monitoring, and ensuring medication safety. Regular follow-up, consistent education, and evidence-based care maintain balance between bleeding and stroke prevention. Before cardioversion or ablation, if atrial fibrillation has lasted more than 48 hours or the duration is unknown, patients need at least 3 weeks of anticoagulation before and 4 weeks after the procedure, or a transesophageal echocardiogram to rule out a clot. This prevents embolic stroke caused by atrial stunning after rhythm restoration. If a patient cannot tolerate long-term anticoagulation due to repeated bleeding or contraindications, left atrial appendage occlusion offers an alternative. Devices such as the Watchman seal the clot-forming area, reducing stroke risk without lifelong anticoagulant therapy. This procedure is reserved for select patients after a thorough evaluation. Scenario 1. A 66-year-old man with high blood pressure and paroxysmal atrial fibrillation has a CHA-2-DS2 VASC score of 2. He should receive anticoagulation because intermittent atrial fibrillation still carries stroke risk. Scenario 2. A 74-year-old woman with prior gastrointestinal bleeding should restart apixaban once the source is corrected. Scenario 3. A patient with a mechanical mitral valve and atrial fibrillation must use warfarin with an INR between 2.5 and 3.5 because direct oral anticoagulants increase valve clot risk. Scenario 4. A patient with stage 4 kidney disease may use apixaban with a dose adjusted for kidney function to reduce bleeding risk. Scenario 5. A 72-year-old with unknown duration of atrial fibrillation scheduled for cardioversion must have 3 weeks of anticoagulation before and 4 weeks after the procedure. Scenario 6. A 31-year-old pregnant patient should avoid warfarin and direct oral anticoagulants. Use low molecular weight heparin instead to ensure safety. Scenario 7. A 78-year-old on rivaroxaban develops a stroke. Check adherence, kidney function, and drug interactions. If events recur despite proper therapy, consider left atrial appendage closure. Evaluate for other stroke causes such as carotid disease or small vessel ischemia before adjusting the plan. Advanced NCLEX challenge. A 73-year-old man with atrial fibrillation, heart failure, diabetes, and hypertension is prescribed a direct oral anticoagulant. He also takes carbamazepine for seizures. The priority action is to notify the provider about this dangerous drug interaction. Carbamazepine reduces anticoagulant effectiveness, raising the risk of stroke. Administering the medication without clarification could make the treatment useless. Recognizing this interaction shows strong clinical judgment. Nurses must think beyond simple orders, identify contraindications, and advocate for the safest evidence-based plan. Always protect the patient from preventable harm through knowledge and vigilance.